Welcome back to Stories and Conversations with Rahel. And this month we're talking about a topic that I'm very passionate about, healthcare. So healthcare access, healthcare affordability, that's the conversation that we're having this month. And I'm so glad to have a guest with me who I've wanted to have on this podcast for such a long time. And he will introduce himself. I don't want to say so much. He will introduce himself. So without much further ado, Dr. Tim, welcome to the show.
Thank you.
Yeah. Do you want me to call you Dr. Tim Theuri?
Works.
Oh, Tim Works. Okay. Yeah. Welcome and good to have you here.
Thank you for having me.
Yeah. Awesome. So introduce yourself. And what I normally tell my guests when they're introducing themselves, please don't be shy. If you want to share something with the public, please feel free. If you're single and searching, all that. I mean, we are inclusive in this podcast, so feel free.
I don't think with the new prices of fuel, you want to share much.
Yeah.
My name is Tim Theuri. I am a dental surgeon by training. I am the CEO of Kenya Healthcare Federation. That's the largest non-state actor in health, aggregating business member organizations in the entire value chain for health. We're the health board for KEPSA, that's Kenya Private Sector Alliance. Elsewhere, I serve as the president of Kenya Dental Association and a board member at Kenya Medical Practitioners and Dentists Council, where we are the main regulator in healthcare. That's what I do.
Yes.
Who I am is I am a man who loves and believes in iteration for the better. In Darwinism, for lack of a better word, it should get better. It can only get better, and that's my motivation each day I wake up. How can I improve the spaces I get into, and how can I inspire the next person? I really always hope that on my deathbed that people will be happy that they interacted with me and the influence I have had on them.
Oh, wow.
Yeah.
That's a tall order.
Yes.
So do you think you're doing that?
It's one day at a time. There are good days, of course, there are bad days.
Yeah.
But I think in the grand scheme of things, when you put them together, the good days will be more.
Definitely.
I'm confident about that.
Oh, wow.
Yeah.
Definitely.
Yeah.
So why dentistry? Is it that you're passionate about teeth? And are you those people, when you meet someone, you're always looking at the teeth, trying to figure out whether...
No, with time, we don't do that.
Yeah.
I don't believe cobblers look at your shoes every time.
I think they do.
No, they don't.
They're looking for an opportunity.
Yeah. And moms don't look at children, and dads don't look at children every time. So, I mean, of course, you'll notice the outliers.
Yeah.
But I think I would have made a better engineer.
Oh, wow.
That is after having spent some time with myself. I think I would have made a better engineer because I'm a sequential thinker and a problem solver. Dentistry is, I think it was an act of defiance because I found medicine a bit mainstream. And I think when I look back, I have often not been on the mainstream side of things. I love challenging systems. I love a little controversy, not too much, but just a little to get things going. Okay. And that, I think that's how I landed in dentistry. I love it. I have practiced it now for 10 years. And it's been quite a journey. Yeah. But now, after having done that for the time I've done it, that has matured. And I think it was time for me now to get to the next phase of my life and career. I've always believed that if you get to be 70 years, and assuming you've worked for possibly maybe 45, if you're lucky 50 of those years, it's not fair to do one thing. It's not fair to do one thing. Wow. So, well, of course, you distill the skill with over the course of time, and you get to be really good at it. But if you have the talent, if you have the time and the capacity, don't do one thing. Try and change, and that cycle can be maybe every 10 years. Change and do something else. And as you know, when your change point is coming, prepare for it. I knew I'm not at 40, but I knew by the time I was getting 40, I wasn't gonna be in practice. That's the time I'd given myself. it's happened sooner. I am happy for that privilege.
Yeah.
And I hope that in this phase, I am able to give it my all and my best and leave the federation, because that's now my 8 to 5.
Yeah.
Leave the federation for the better. If time and chance accord me the privilege, maybe 5 years at this, and then now we hand it over to the next crop of people.
Yeah.
Yeah.
Wow.
Yeah.
You're dropping some bombs. I don't know if you can hear it, but you're dropping some bombs. This is really amazing. So KHF, Kenya Healthcare Federation,
Yeah.
how did you get into it? Is it something that you had eyed for a long time? And you talking about wanting to make change, wanting to make difference, is this a place where you're eyeing for a long time and you said you have to get in here so that you make the change in the healthcare industry?
So I've only attended 3 interviews in my life. One in a hospital where I thought I wanted to work. And they never got back to me. And I was that for that one for sure, it was just a Hail Mary. I was just like, let's see what the bait catches. The other one was to be a CEC in one of the counties.
Oh, wow.
And it went all the way through to assembly approval, and it came in. And after thinking through it, I declined the position.
Yeah.
And many years later, I am happy I did.
Oh, wow.
The third one was for KHF CEO. And I'm happy it went through. So I saw an advert and I was like, this looks like something that could be good for me, and I could be good for them. And KHF has been there for now possibly 15, 20 years. And it aggregates the people in health, the entire value chain. And that really fascinates me. Business processes fascinate me. And I am good at connecting people. I'm good at seeing the bigger picture. And I thought that this would be the perfect spot for me to do that for healthcare. Yes.
Oh, wow.
Yeah.
That's really interesting.
Yeah.
So, I mean, you've been in KHF for now
9 months.
9 months.
Yeah.
So there's a lot that's happening already.
Yes. Yeah.
And I mean, we were at a forum the other day and you were talking about, or rather the conversation was around the digital health superhighway. And you're one of the key proponents to this particular agenda.
Yeah.
So why now? Why are you doing this right now? Is it because that, the healthcare industry is fragmented and you want to see that change? Or what's the main reason why you're doing this right now?
Like I said, digitization and digitalization improve business processes, whichever way you look at it. They bring accountability, they bring trackability, you're able to assess costs, you're able to ensure patient safety, you're able to optimize the system. And since we have finite resources, any process that helps in optimization and management of the resources is something that we should really pay attention to. And we are doubling our medical knowledge every 2.5 years now. And that is the amount of information that we have. It's doubling every 2.5 years. And we cannot rely on pen and paper to store that information anymore. So we must generate it and store it at the rate at which the world is storing it. How I look at it is when we are buying vehicles for, let me say, our politicians, for lack of a better word. When we are buying the guns that protect them, we go for best in class, right? When you are refurbishing the houses they live in, we go for best in class. But for health, you want us to start a conversation on resource limited setting. No, it can't happen. Even for health, we go for best in class. The people who started the agrarian revolution, whereas they were brilliant at the time, when I look back, possibly not, because they are the people who now make us work. This is what they had in mind, I think, when they thought about a society. And they domesticated wheat, which I think is the most successful species to date. And in that process, they iterated and made the process better each time until the human civilization as we know it stabilized and can feed itself and can do all those things for itself. And that's how I look at digitization. It is the process, or it is a platform that will help us stabilize how we bring healthcare in Kenya.
Yeah. And I mean, you say such important things that are very, very key to obviously pushing this agenda forward. But Tim, the fact is, this has been there for such a long time. I'll give you an example. There's been MTBA, Slade, and all these other solutions, and I can name so many of them. And they've been there for so many years. But it feels like, it's, I don't even know how to explain it, because I still try to figure out why have these solutions not gone to the level that they need to go to, right? They're supposed to be at a certain level where we have proper access to healthcare, affordability, and all that. But it feels like it's a struggle. So I don't know if it's the political side or it's something else that we cannot see that is causing these things not to move as fast as they can or they should.
I think, healthcare is one of those topics that that are sensitive. They are touchy. It's a touchy topic. And it would be very interesting to know that most of the population in the country is within 1 hour of a healthcare facility. That is the average. Of course, the numbers are a bit worse in the far-flung regions where we have our nomadic countrymen, and it tends to be better where we have high population densities. And digitization, what it does when it comes to offering of healthcare and what you've mentioned, I think for the first time we have political goodwill to make it happen. And it's not only the third-party partners and enablers who are important in the conversations, just like the companies you've mentioned. For it to work very well, we must have buy-in, right? Because if you have people who are not willing to share data, what do you do? If you have people who are willing to share data, but they're sending the wrong data, all right? If you have people who are willing to share data, they're sending you the right data, but you don't have the platform. Then you see, there are many layers to it. Unique identifiers. We've generally known that our identity cards are a unique identifier. But I can see there's a conversation of a Maisha card in the country, so I don't know what that will be. But we are watching it to see how it integrates with health. Coding of diseases. We have the different codes, ICD-10, ICD-11. Now we are on ICD-11. And it's important to migrate everyone to that platform so that hopefully when this works and all the hospital integrated management systems are facing each other and communicating with the platform, then the data that they're sending should be sort of standardized and anonymized so that we don't have non-medics looking at confidential medical data. We have the Data Protection Act, the commissioner who's trying to operationalize the act, rules and regulation around the same. Health needs separate rules and regulation due to the nature of the business itself. I've seen something happen around that. We also have a digital health bill that is now undergoing stakeholder engagement. So I think the space looks quite optimistic. The one government pay bill is an interesting one, and of course it was an executive pronouncement that all government services will be paid on one pay bill. Of course, each of the sectors have its own nuances. For example, tourists, when our tourists that are attempting to get into the parks, you've seen the queues. For health, it's a bit different because people don't come to hospitals for fun. And say, for example, I've asked for an X-ray, but between the point of me requesting and you paying, the X-ray breaks down and possibly that's the only 500 shillings you had. How do we take care of that? But as providers, we're really trying to think how we can best take care of it. But those are the small challenges that we must think about for our people and our countrymen.
I mean, I love how optimistic you are.
Oh, I am.
Yeah. For me, I've been in this space for a minute now. And I mean, I've gone through the motions and I've been in, contributing to organizations who are trying to actually make a difference in the industry. But then you've talked about political goodwill. So let me challenge that a little bit. Kenya is a leader in this region in terms of healthcare and all these other things that we're trying to do. But Rwanda is far off in terms of healthcare access, right?
Okay.
So if there's political goodwill, and political goodwill is obviously the key element that will actually push this agenda forward, right? Very fast. So did this political goodwill start now? Are you saying it's a time thing? It started now? Or is it that we have not had the right people in those positions?
If you think about our country and shrink the entire government administration to Kajiado County, that is Rwanda now. Because Kajiado County is bigger than Rwanda. All right? So, whereas there are many good things that are happening to us in our sister country, we must look at them in context. Okay? Because if you have an entire military taking care of a county like Kajiado, an entire healthcare system that is focused on that, the geographic area, and of course the outcomes could be a bit different. But imagine we are 52 million of us, and that entire population is an hour away from a health facility. The indicators are not too bad. They can be better.
Yeah.
And possibly it's a bias, it's an optimistic bias at how I look at it. And being a sportsman, of course, I'm a bit competitive. So maybe there could be a small bias there. But that's how I look at it.
Yeah.
That they are shouting a little more about it is a good thing. But I can assure you that we are leaps and bounds ahead. In terms of training, we train their doctors. In terms of benchmarking for systems, people come here for that. In terms of caseload and case management, we have that ongoing here. The advantage Rwanda has is it's a young democracy. And they've had the foresight of doing it right from the beginning. When we were coming up in the 60s, you can imagine, what systems did we have? Not much. If you look at the videos then, possibly like the unfortunate incident where Tomboya was shot, the doctors that handled him didn't have gloves, right? The systems that they were using to resuscitate, they were quite rudimentary when you compare what we have now. Yeah. So the way we've grown, you can't underscore that. And the lessons therein are very important. And for Rwanda now, they are learning with other people's textbooks, which I think is a fantastic way to do it. And I think is the best way. If in life you mustn't get into a class to soak the lesson, don't. Yeah, learn from someone else and soak the lesson that way. And I think they're doing that. And I think what you're talking about is their catch-up rate. Their catch-up rate is fantastic. And if they keep at it and we don't do anything different, they'll of course get ahead of us. But we have the advantage of scale, size, and a very enterprising population.
Yeah. I mean, I hear you on that, but what trumps the other? Is it systems or is it access for the people?
For the common mwananchi, of course, access is
It's
everything.
key. Yeah.
On 20th of October, we are launching universal healthcare again as a country. Third attempt, possibly third and lucky. But on 21st, once we've made those pronouncements, what will be the Kenyans accessing? Yeah, if we can answer that question honestly, then we begin to solve the problem from a very practical and pragmatic way. Access is everything. I want, when I am not feeling well, to walk into a hospital, be seen, get the correct diagnosis, get the right medication, and walk from that system. That's what people want. Technically, I look at many more things than that. What is my order refill rate at the pharmacy? What is the level of training of my doctors and nurses and all the people who are supporting them? What kind of health information management system do I have as a manager? But I don't think that's the important conversation. Good health is like good drainage. All right? You only know it's not there when it's not working. Okay? Yeah, but we'll all be happy. You're working here, the drainage is working fantastic underneath. But the day it stops working, you're like, things are wrong here. Yeah, but that's what we should aim to achieve. And just like good drainage, you must be able to foresee what will be my usage rate 20 years from now. Where do I want to build houses 10 years from now? When I look at Nairobi metropolis, where will the roads be? Yeah. And as you're doing that urban planning, drainage and water go hand in hand. So the same case for health. We must do those projections hand in hand with how we are looking at our population demographics. Non-communicable diseases, hypertension, diabetes, cancer are on the rise. Are we preparing a system that will be ready for those? We have pretty much taken care of our tuberculosis and HIV and malaria problems. There are still a big killer as well as diarrhea, but the systems that handle them are pretty robust. But now we must reorient the system towards that. And that's what now you hear a lot of health system strengthening towards sustainable, affordable healthcare.
Yeah. But at least we agree that access is the most important.
It is important. Most debatable.
Really?
It's debatable.
Okay.
Yeah.
We'll not have that conversation today.
Yeah.
But personally,
it is important.
Yeah.
Yeah. It is really important.
I think it's the most important.
What I think is most important is the quality of the citizen. I'll put it to you this way. When the citizen wants better and they know better, they will get better.
For sure.
From the service providers, both in private, not-for-profit and for-profit, as well as public. But if you have a citizenry that doesn't know, maybe if you suffer from this disease, this is what you're supposed to do, and this is what I should get, then the problem is far much bigger than even simple access. Because if you have excellent access by people who do not know and do not understand, you clog the system. Because I'll come for a simple flu, I'll come because I went out yesterday, I have a headache. Access is free. So we must also prevent wastage, fraud, and abuse. And that happens when people know.
So access and sensitization.
Fantastic.
Awesome. So you touched on another topic that obviously is so big for all of us. You hit C.
Yes.
Why do you think it failed the first time? And don't give me a politically correct answer. Why do you really think it failed the first time?
I think it's the financing models. We've tried input financing. We've done some sort of output financing for it, where we say, come, be seen at the point of financial. Okay, there are three types of discharge. There's physical discharge, where you've come, umeonekana. If your audience is largely Swahili speaking, you've been attended to and you're going, and you've been released. That is that physical discharge has happened. Medical discharge is when the doctor says you can go home. And then there's financial discharge, where you have paid your bills, or your bills have been taken care of, whether by yourself or a third-party payer, and the hospital says you can go. So at the point of financial discharge, government used to take care of some components therein. And that's why NHIF began giving packages for oncology care, for surgical, for transplant, and all those things. And I think you've been seeing conversations around those. And then there is the other model where I collect everything that you could ever need. Drugs, surgical equipment, human resources for health, facilities, give them to you and tell you, go ye for them, treat the people. What we are seeing now is sort of a hybrid that is taking it from both top down and bottom up, in keeping with the current government. And we are seeing a lot of legislative changes to bring policy stability into the space. And it's buttressed against 4 pillars: human resources for health, digitization, healthcare financing, commodity security. If we get those right, then we'll be able to deliver affordable healthcare. I may not call it universal health coverage. Affordable health is what we may be able to deliver. And it is based on equity, where those who have contribute a little more than those who don't have, but at the point of care, we are all getting the same care. So there's an aspect of equity distribution in this conversation. So if you are salaried, Uh, for example, like you, the people who the band says it's 30%, or this whichever is higher, and the whichever is higher.
Yeah.
And then there are those who are who don't have the privilege to get something like that.
Okay.
We take care of them.
Yeah.
Yeah.
So it failed because there are no processes in place.
It was multifaceted, I think,
Okay.
all the way from did the people understand what the counties involved. No, health is a devolved function, sort of, in the constitution. But I think by and large it's shared.
Okay.
And I really hope that, let me just digress a little, and the elixir to the problem that we face at the counties especially is that if we're able to get blueprints for health in the various counties, that would be amazing, where the governors will be able to come and say, or they agree, as a county, this is where we want to take our healthcare system. Do a 15-year blueprint. You as a governor, do your 5 years, well, that's what they do, your 1 term, 5 years, and then leave it wherever you'll have left it. The next person comes and picks it and moves on with it. Just like the way corporates do. You never hear a CEO joining the company and saying you're starting afresh, you're building ground up. No, it doesn't happen. You build from where the other person left. That practice should percolate into especially county administration.
Yeah.
And it's going to be fantastic.
Awesome.
Yeah.
So let me ask, you've said you're a problem solver.
Yes.
So in your tenure at KHF,
Yeah.
what's the one main challenge that you want to solve and will definitely be part of your legacy?
I want to embed the federation in processes. The budget policy making process, the Ministry of Health strategic plan making process, at county levels, when they're making their county integrated development plans, I want the federation to have a voice there because they represent non-state actors. Traditionally, non-state actors have been viewed with the lens of for-profit. And that is not a bad thing because these are the same people who underwrite the health that the government uses as our taxes, where the government uses our taxes to bring to the common mwananchi. We, in the non-state actors, deliver about possibly 38 on the lower side and north of 50% of healthcare in the country. When it comes to commodities, I can confidently say we do more than 60% of commodity or commodity security in the country is buttressed on us. So we must view it with that lens. And banks, for example, or financial institutions, they employ less than 100,000 Kenyans, but they contribute what? 48% of our taxes. Yeah. So, yeah. If you look at it that way, you may not like the interest rates they give you. You may not like some of the practices that they stand for. But on the other side, the roads that we drive on, the agriculture that we get subsidized fertilizer in, security, and all those other social functions that government delivers, they do it from the money that they collect for these people. Yeah. So that's what I'd like to see the federation be at. They must be, I'd like us to be the honest broker in health, the neutral voice that brings sense into the room when we walk in. We want to bring down the silos of information that we have and get the sector talking to each other in an honest way. I want us to reward best practice and condemn and punish those who do not stand for the same. If you are fraudulent, if you are not doing the right thing, let us call you out because we are dealing with health. Unlike lawyers, our mistakes don't go to jail. Yeah, our mistakes go to the grave.
Definitely.
Yeah.
So as we come to an end of this conversation, what's the one thing that you would want to share with the audience about, your next steps, where you want to be, where you want to go and all that? What's the next step or what's the next thing for you as Tim?
I think the journey of my life is not focused on me. And I am just an agent of change. And anyone who can use me to bring change, I'm open for that conversation and that. And where I'd like to be is I'd like to free my time and that means I have to work a little now so
Yeah.
that I'm able to free my time.
Yeah.
And when I free my time, I want to give of myself to society so that we are able to influence and change and improve lives for our countrymen. Yes.
So if someone wants to, support you in this, how can they get to you? Do they just write to you on LinkedIn? Where can they get you?
I can give them my bank account.
Wow, please
Fast.
do. Please
Fast. And get a healthy deposit.
do. Okay.
But I'm on it's Tim Theuri on
Yeah.
most of the social media platforms.
Yeah.
And yeah, that's it.
Okay.
Yeah.
Perfect. Thank you so much for coming to the show. We really appreciate you. Thank you for your time.
Thank you.
for honoring us with your presence. Stories and Conversations with Rahel is all about life, career, leadership, and healthcare, a topic I'm very passionate about. Thank you so much for watching. Share, like, comment, and subscribe for more.